Hi, welcome back to another session with me. This is an extended live stream. We started earlier this morning. We had to interrupt, but we're back. I've got really interesting women's health topics I want to cover with you. How are you doing? How was your weekend? Where are you watching me from? Give this video a like, please, if you are joining us. Um, and watching from different parts of the world, I would love to know, but give this video a like first. I wanted to share thoughts and comments on different questions that come into the live stream, a few quite interesting ones that I've seen from the last week or so. We're not just going to be scratching the surface. If you watched the first stream, you notice that we really went deep into trying to explain background and providing you with actionable tips. So we're going to continue with that. Then we covered mainly pregnancy related things. We touched a little bit of vulval, vaginal health, cervical screen. So we're going to carry on that tangent now with more vulval health, birth control, bacterial vaginosis kind of conversations. So this is where you need to be to get the information that you need to have for beautiful and healthy bodies as women. Okay, so before we carry on, I need to share our disclaimer because you guys remember that we are all about providing health information that would help you to make better decisions, absolutely. But I cannot provide health advice. So I would always say, please go and see your own medical provider you're registered with so they can assess your symptoms properly and make sure that you're getting the right information for your health. So thank you so much for watching. Give the video a like. Where are you watching from? Please let me know. Without much further ado, let's just get cracking into the very first subject. Like I said, we're going to be looking more at cervical screening. We started that off earlier in the day, but we're looking more at cervical screening at this point. So let's get cracking. The first question is, why getting screened for cervical cancer post-menopause is crucial. Now, I didn't even think this was a thing, but I'm glad it's coming to my radar because, so you don't just assume things. I think some people feel that once they've hit the menopause, they're not really bothered about having the cervical smear. That is such a wrong idea or belief. And I want to explain to you why that is. So, cervical screening, you might know it as pap smear, depending on where you are in the world. When I trained, we used to call it cervical smear here in the UK, but we now refer to it as cervical screening because it's a combination of having your HPV test, so that's the primary HPV test, as well as looking at the cells of the cervix to check for any changes right now that might suggest future cervical cancer. So that's the purpose of having the screen done. Okay, so I'm just checking to make sure that I've got all the bits and pieces that we need to have. So let's just have a conversation around this because there are some amongst us who feel that after menopause, you no longer need to have the test done. That is so incorrect, and for a number of different reasons. In the first stream, earlier this morning, we talked about, especially if you're having the cervical screen for the very first time, we talked about what to expect. We talked about high risk versus low risk HPV, low risk HPV associated with genital warts, but high risk implicated in nearly all cases of cervical cancer, which is why the primary HPV test is crucial. That's the first thing that we're looking at because you want to check for the presence or absence of that virus. And then secondarily, they can then look at any changes in the cell. So, when you go for your test, you have this information. But yeah, this idea that when your periods stop and you go through menopause, you can stop thinking about cervical screening is far from the truth, okay? That's a really dangerous misconception. Really important to stay on top of your screenings after menopause. Okay, it's crucial to do so. Okay, so the NHS cervical screening program, I'm using that as an example because, as you all know, I am an NHS women's health GP. I work in the NHS. I'm also a private doctor. But the NHS cervical screening program is for women aged 25 to 64. So we start to invite women from the age of 25 to come and have their cervical screening up until the age of 64, which is when you receive your last invitation the year you turn 64. Now, if you stop having your screening before this age, you are unprotected, okay? Like I've said, the primary cause of cervical cancer is HPV. If you're younger and so have a younger immune system, okay, you're more likely to clear the HPV infection because to date we don't have an antiviral or treatment for the HPV. Okay, so it can be cleared by our immune system, and a young, strong immune system is able to do that better than an older immune system. Okay, and actually, HPV infections can persist for decades without really giving any obvious sign of illness. You understand? So, the risk of an infection that persists for years, even though it doesn't really cause any obvious problems, can increase as you grow older because the immune system becomes less strong, less robust. Okay, so that is why screening is your best defense against this process of the HPV persisting in the tissues instead of being cleared, and then because it's persisting, increasing the risk of developing cancer. So for many years, like I said earlier, what we used to do was the pap or cervical smear, where what we would do is take cells from the cervix, that's the neck of the womb, go and look at those cells underneath the microscope, and then see whether there are early signs, early changes that indicate that 5, 6, 7, 8, 9, 10 years down the line, this change could result in cancer. That's what we used to look for. But these days, many countries, including us here in the United Kingdom, the first test we're doing is often an HPV test. So the HPV test is detects the virus itself, and so it's more sensitive and effective at identifying if you are a woman at risk well before any changes even happen. So let me know, in the comment section. I'm just going to quickly check. I'm just going to be switching screens so I can monitor the comment section. If you're here and wondering about this, have any questions, want me to clarify this a bit further, please let me know. And of course, while you're here, do give the video a like. That would be most appreciated. Okay, but what we're saying is that we should remember that you can also still have the test that looks at the cells. Okay, so we're not throwing that away. We're just saying that the first step is to check for the virus. Okay, so there is still that option for the test where you're going to have a look at the, sorry, I'm just changing my screens. Yeah, where you're still going to have a look at the cells to check for any abnormal appearance. And of course, things will then progress depending on what your screening results are. So what are the issues? Okay, what are the issues around neglecting your test after menopause? You have lower estrogen at that time. That can increase the risk of vaginal dryness and thinning. So sort of like a shrunken or less flexible vagina, which can create things like your speculum test, which is the way that we use to get the tissues at the cervical screening test. Can make the speculum examination more uncomfortable. So I know that this is a barrier or a challenge, that as you grow older, you're less likely to want anybody to sort of try to put a speculum that will make you feel uncomfortable. However, you have every right to a comfortable experience. And so there are many ways to get around that fear of the discomfort, if that is what is preventing you from going to have your test, because you think, oh, I'm past menopause, they're no longer sending, I'm no longer at any risk of this. Well, whereas you are, for the reason I've explained, that with a less robust immune system, there's still that concern. So you're going for your smear, have the conversation with the nurse or your doctor, whoever is doing the test for you, that you're conscious that you are around menopause or after menopause, your tissues are dry, and you're just worried about the discomfort. And then ask if you can have a smaller speculum. You could also ask to make sure that they wet the speculum with water so that it's not, especially if you're dry, so it's less painful when they're putting it into your vagina. And of course, simple techniques like taking deep breaths during the procedure. Now, the thing is, usually a very quick, simple, standard procedure, literally a few seconds to pop the speculum into place. For most women, I appreciate that there can be some complications because there might be different positions of the cervix, of the womb. That usually is not an issue that you bother with. It's usually a problem on the other side for us clinicians who are trying to do the smear for you. But that is some of the examples of what could make things a little bit more difficult. So otherwise, it's a fairly straightforward investigation or test. From the time that you get onto the couch, from the time the speculum is put into the vagina, from the time that the soft brush is gently swept around your cervix, literally a couple of minutes from the time that you're then asked to put your things back together. It's worth it. It's worth it. 2 minutes, if we want to say within an entire 10-minute consultation to check that you're safe. So please, if you are under 65 and haven't had a test, in over 3 to 5 years, contact your surgery so that you can get one booked, okay? Then let's reframe your mindset around what the test is, not an inconvenience, but actually something that can put you in the right place, assessing your risk, putting you in the right place for preventing cancer from developing. So you've got this tool at your disposal. Why would you not make use of it? Why would you not take advantage of what you need? And then, of course, lastly, I would say always be open with your clinician, with your nurse. Explain if you have any qualms or any anxieties about the test. They will certainly take that on board. Nobody wants you to feel uncomfortable. Actually, an uncomfortable patient makes the work harder for me. I'd rather that you're nice and relaxed. I'm happy to talk you through the process of what we're doing. Okay, so please feel free to be open. Okay, guys, let me know if you have any questions on this. Drop them in the chat section. Let me just swap screens to check I've not missed anybody. And of course, in the replay, we're going to just change track here and move on to the very next question. And then we shall proceed. So bear with me a second while we just move on to the very next one. Are you tired of being told your debilitating pain is normal? You're not alone. Many women spend years struggling to be heard. I'm Dr. Sylvia, a GP and women's health specialist with 15 years of experience working with women just like you. I provide private consultations to thoroughly investigate your symptoms, create a working diagnosis, and map a personalized treatment plan so you can get back to living your life. We can explore unexplained period pain and heavy bleeding problems, suspected or managed endometriosis or adenomyosis, polycystic ovary syndrome PCOS, fertility awareness and preconception advice. So what can you expect? Initially, we'll have a 30-minute consultation where you are the focus. We will review your history in detail, discuss potential next steps like scans, blood tests, or a referral, and create a clear plan for your relief. So what are you waiting for? Click the link in the description box below or in my bio, or just visit yourgpconsultation.com to book your women's health assessment now. Are you tired of being told your debilitating pain is normal? You're not alone. Okay, so we are back now with the very next topic, which is the hidden effects of birth control on mental health. I know that lots of people will have something to say about this, and I want to address it head on. Okay, I want to address it head on because I see women worry about using birth control, particularly because of the effect of the hormones on the mental health. So let's have a look at this. Let's have a conversation. Let me know your thoughts. Okay, let me know how you're feeling, particularly at this moment. If you're using birth control method and you're thinking about coming off it because of something to do with your mood, anxiety, depression, and so on, or if this was your experience maybe a couple of years ago or in the last 6 months or not, please let me know. But for many, many years, women have complained of mood changes, anxiety, depression while on hormonal birth control. And I'm sorry to say that many times told, oh, it's just in your head, which is awful. I haven't said that to anyone personally, but I do know that medical gaslighting is a big thing. So I definitely know that many women have had that response. Okay. However, modern studies, neuroscience is proving what women have known all along, that there was a link between the pill and your mental state. It's not just imagined, it is biological. Okay, so what is this science? I mean, I could share different studies and maybe I'll just put the link to them in the description box when we finish with this. But these are just looking at certain chemicals we call neurotransmitters that work in our brain, or our bodies produce, and they work in our brain. And what we're finding and being proven with data from studies is that these hormones, these man-made or human-made hormones that are in our birth control pill, especially the progestins, can influence the delicate balance of those neurotransmitters in the brain. So what are these neurotransmitters? Two examples that you probably at least the first you'll be very familiar with is called serotonin, often known as the feel-good hormone. So when we say, oh, go and exercise and how it builds up your mental health, that's an example of a neurotransmitter. And the levels of serotonin actually increase after a period of exercise, and that way improves your mood. And it doesn't have to be strenuous exercise. It might just be taking a walk outside in the park, a brisk walk, brisk jog, dancing. It increases the levels of serotonin. So what we're finding, or what these studies are telling us, is that some hormonal birth control can lower the activity of serotonin, which can in turn lead to feelings of anxiety, irritability, or depression. Okay. And another neurotransmitter is called GABA, and this is another one that's formed in the brain, and part of its primary work, or what it does, is to calm us down. It's been shown by these studies that the progestins in the birth control can block those receptors, okay, and so reduce its calming effect, leading to increased anxiety, and all that's associated with that. Poor sleep, for example, just that feeling of being jittery and not settled. So there are studies showing us that this is what's happened, or what is happening. They're using advanced brain scanning techniques and finding that women on the combined pill, for example, had a significantly different stress response in their brains and higher inflammatory markers that are linked to mood disorders, okay? So before you run away and say, oh, we said it all along, oh, blah, 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 no to the pill, no to the, hang on, hold on. It doesn't happen in everybody. So let's think about it, okay? So let's calm down. I would like you to think about birth control pills like the way coffee affects us differently. I don't know how you are with coffee. I know that I can't do more than 1 cup, sometimes a day or every couple of days. I can't do more than that. It just messes me up. There are some of us that avoid caffeine altogether because just a little bit can make them feel really jittery. They can't sleep, can't function. On the other spectrum, there are those that need 6, 7, 8 cups of coffee to function. It boosts them, it's alert, it makes them alert and stimulates and all that. What am I saying? That we're different, okay? Yes, we all have neurotransmitters. Yes, this data or these studies are finding these links, but it's not everyone that's affected. So there has to be something about your genetic makeup, your personal history, perhaps of mood related problems, and perhaps the type of progestin in the pill that dictates the response. Because especially in the last 10, 20 years, there's so many different types of these human-made progestins or pill formulations, okay? Some are more testosterone-like, they call them androgenic, while others are more anti-androgenic, so less testosterone-like. And that profile can dramatically influence how you feel. So, when you go to your doctor, and, I'm saying this, I want to appreciate the fact that sometimes we do, as doctors, we do get it wrong. But sometimes when you go and see your doctor and you're talking about how you feel on the pill and, the experience with this particular type of pill, and your doctor suggests switching to a different one, it's not because, they just want to keep you on hormones and keep you on hormones for the sake of keeping you on hormones. It's actually different pills have different profiles, and so you may have a better experience on an alternative pill compared to the previous one. And unfortunately, sometimes it's not always written on the pill packet to say which is more likely to cause a problem, but we can sort of roughly gauge that if one is more testosterone like compared to being anti-testosterone, you have different potential effects from the pill. So let me just mention that it's not just about the combined pill, okay? So progestin-only pills, the coil, the hormonal IUDs, implants, and the injections that contain progesterone all have the potential to affect mood because they still introduce these synthetic hormones that can interact with your brain chemistry, okay? Some of them might have fewer effects. For example, the coil, because the coil is sited in the womb, so its action generally within the womb may have less effect on other parts of the body, that's compared to the pill, for example, or the injection where is going to circulate in the bloodstream. So what am I suggesting? Am I saying down, drop, everybody stop taking the pill? No, that's not what I'm proposing here, because like I asked you earlier, there are some people who do take the pill and who don't have any problems with the pill and or any progesterone or hormonal birth control method, and it's been effective in helping them to manage their life, manage their family planning needs, while there are others who have very horrendous experiences. So what I will say is, please, if you suspect your birth control is affecting your mental health, here are my suggestions, okay? Get a diary, get a mood diary, open a diary, and that can be as simple as on your phone, or use a planner or something for 2, maybe 3 months, okay? Keep a simple log of your mood, specifically mood, experience of anxiety, sleep, because when you do come to see your doctor, this will provide powerful objective data. You can say, oh, for 17 days out of 1 month, I had this experience, or for 3 weeks out of 1 month. And this is not just a sense of, oh, well, I feel it's been this. And I don't mean to say that the doctor will not take you any more seriously, but I'm just saying that is a powerful, just think about it, that's a powerful way to reinforce your experience, when you can say, well, I've tracked my mood, I've tracked my symptoms over the last 2 or 3 months, and here's what I find. That's really, strong objective data. And then go in and book the appointment with the doctor and be focused. Please say something like, I've been using X method and I've been tracking my mood and I'm experiencing these symptoms, and I'm concerned that my experience is linked to the pill. And so have a conversation. Like I said, your doctor might say, okay, fine, fair enough. This is really useful data. How about to consider an alternative pill, or have other conversation with you. The goal is to have a pill or something that controls your fertility without compromising your mental well-being, because your mental health is a valid aspect of your overall health. So nobody wants you to stay on medication or on treatment that's going to cause you problem. That is definitely not our intention. So please let me know what you think. I'm really interested in working out whether you have recently experienced any changes in your mood, in your mental health, in your anxiety because of the pill. Share that with us in the description, please, so that we can, have that conversation. Okay, guys, thank you so much for watching. Give this video a like. I'm just having a quick look to see if anybody's popped a question in the comments. Oh, hang on. To see. Okay. No, we haven't. I think a couple of people in here. So guys, please give the video a like. That would be much, much appreciated. And then let's move on to the very next one. Quick break before we do that. Give me 2 seconds. Okay, excellent. Welcome back. Thank you so much. So let's move on to the very next topic that we're considering today, and that is menopause, navigating menopause, and having a conversation about HRT. Ooh, what can we say about HRT in 2 or 3 minutes? There's always a lot to say about HRT, but I do want to, in this space, just talk about fears of HRT, going back nearly 20 years and where we are now, just in case somebody is not sure of the science. I'm really glad that we're having more and more conversation around HRT. We're having more and more thinking about women's experience. It's not something that we're hiding from. We're recognizing it has its values. We're recognizing that it has its risks. And we're having clear conversations. And I think sometimes sometimes the space may be what's the word now, the space may be very busy. So if that's the case, if that's you, then let us chat about the menopause, the HRT concern, the fear of cancer from 20 years ago, how that started and where we are now. That's what, I want us to look at, because I do still get that, people worried about, oh, would this be suitable for me? And I do have some videos on the channel. So if you've got, some time after this, go and check out the videos on the channel under my menopause playlist, exploring HRT, whether you can use HRT in certain conditions or what are the risks of using HRT. They're quite well described in the videos. And of course, you can ask me a question. You can share it in the comments. If you're UK based, you can come to your GP consultation, please. It is not just period pain issues. We also definitely talk about menopause. We provide menopause support, perimenopause, period related issues, fibroids, endometriosis. One thing I've recognized recently is the increasing frustration that especially women with gynecological issues face when there isn't time in your GP appointment, or you're waiting several weeks or months to get an appointment to have a conversation. It may not necessarily be for a specific intervention, but you want to have a conversation to clarify what your experience is, check whether you're doing the right thing, check what else can be done. And it's difficult to get that. This is why I have your GP consultation, and I welcome you I invite you, if you're based in the United Kingdom, please check us out. It is worth having a conversation with a doctor. I'm a women's health specialist GP. Able to provide you with evidence-based information based on whatever symptoms you're going through. So check out the yourgpconsultation.com, book an appointment, and let us have that conversation. Let me just have a quick look and check that audio-wise that we are in the right place. It is worth having a conversation. Yeah, we are. Thank you. So anybody who is watching, I've got a few people I can see lurking. Always happy to have you guys, even if you're lurking. But if you don't mind saying where you're watching from, that'll be lovely. Okay, so nearly 20 years, there's been that cloud of fear over hormone replacement therapy. Many millions of women have been frightened away from using a treatment that could give or make dramatic improvement in the quality of life. Sorry, my nose is a bit tickling. Okay, so it's a treatment that can provide dramatic improvement in the quality of life if it's suitable for you. And in 20 years, the science has evolved, a lot more studies, a lot more data. So where did this fear come from? So there's this study that if you just Google HRT and you're looking in the history, you'll come across this thing called the Women's Health Initiative, WHI study, which was stopped early in 2002 because they found a small increased risk of breast cancer, blood clots, and stroke in women taking HRT. Now, I'm not downplaying any risk here. Even one is big enough. Okay, we're just when we say small, it's in context. Okay. And we're talking about context. There was a very important context that was missed because the thing went out into the media and it snowballed so quickly. The key contexts or nuances that were missed at that time, that the study was carried out on older women. In fact, the average age of those women was around 63. And those women were a decade or more past menopause. We know that menopause symptoms, in fact, many of us already getting to the menopause in our late 40s, into early 50s. In fact, the average age here in the UK is about 51. But in women of Black origin like me, it starts earlier. Okay, so women are already experiencing perimenopause symptoms in their late 40s, very early 50s. So well before the age where the average woman in that study was conducted. So, and then the other thing is that they were using older hormones, older human-made hormones that we hardly use in first-line treatments today because there's so many advances using body identical hormones that are friendlier to the system. Okay, so it was wrong of them to just pick up, okay, yes, it caused a small increased risk of cancer, but this was in an age group where the risk of cancer is already higher compared to somebody in their 40s or late 40s. So they mapped those results onto a very different age group, really. And so that caused the fear. So today, what is our reality when it comes to HRT? We're using body identical hormones that are chemically identical to the hormones that our ovaries are producing. That's estradiol and progesterone. And so the likelihood of risk is a lot lower. What is the safety profile? So a healthy woman who starts HRT within 10 years of menopause and under the age of 60. So 10 years, within 10 years of menopause, that is when she first starts the symptoms, and she's under the age of 60, the benefits overwhelmingly outweigh the risks to relieve debilitating symptoms. I have videos on the symptoms of menopause. I have a lovely friend. We go to the gym together. She and her mom never experienced menopause. It's like, what are you people talking about? And there are some of us that way. But there are others who have really shocking symptoms. I mean, people will say, I nearly died and I didn't know it was menopause, and all sorts. So it's like a spectrum, isn't it? Let me just say, for an example, the risk of breast cancer associated with most types of HRT, listen, is significantly lower than the risk from being overweight or drinking alcohol regularly. How many people do you see running away from being overweight or drinking alcohol? That's what I mean about the nuance and the context being so important. Okay, so there is strong evidence that beginning HRT early, around the time of menopause, could actually even have a protective effect on the heart and the bones, because what the heart and the bones are experiencing that can increase the risk of things like osteoporosis, that's thinning bones, or even heart disease, is the loss of estrogen. That's what menopause does, isn't it? But HRT is putting that menopause back. So if you're taking HRT and it's in that early phase, you might actually get a beneficial effect, not just on the relief of symptoms, but actually protecting the heart and the bones. So don't forget that HRT is more than hot flashes. It's a benefit to the entire body. Hot flushes, night sweats, tick, 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 yes, but it also helps with that brain fog and mood swings, and we're pretty quiet about that. Many of us just willing to accept it as, oh, getting older. It's an what do we say? It's an older person thing, okay? But taking HRT can help by stabilizing hormone levels in the brain, so you're not having peaks and dips in the hormone levels that can result in that brain fog. What about what we call the GSM, genitourinary syndrome of menopause? All that means is that dryness in the vagina, that pain that happens during sex, and that problem of having recurring urinary tract infections. All that simply because of reduced estrogen. Taking HRT in the right time, early on, can also help to reduce those symptoms. What about joints? We just talked about bones, but what about your joints, the skin? So it's actually the most effective treatment for preventing osteoporosis in postmenopausal women. So there are many benefits and we're hardly talking about them, and there's more of a fear even now in the last 4 or 5 years, where we've been more vocal, thankfully, about menopause. And here in the UK, we're having bigger conversations. You might have heard that it's going to be part of the NHS health check from 2026 if everything works according to plan, which is an excellent thing, because then the conversation starts and we can be talking about symptoms that otherwise may have been swept under the carpet and assumed to be something else. So ladies, educate yourself, okay? NHS website is there. Askaway Health is here to provide you with evidence-based information. Don't just go with what you see on the news, on TikTok. Come to evidence-based sources, okay? If you're trying to have a conversation with your GP and they're not very keen, because it is possible that some GPs do not receive specialist training in that area, then it's okay to ask to be referred or to find one who is like myself. I'm a women's health specialist GP. I have a qualification, certification in menopause care. So we can provide some more detailed information that perhaps our colleagues who haven't studied women's health as a specialism within general practice can do. Okay, so yourgpconsultation.com is here for those of us in the United Kingdom. Okay, and when you're going along to your conversation, again, I'm a fan of diaries. Honestly, okay, I've got to my daughter, to put things like her periods, get the app or get something to track, but have it somewhere written down. For years, I always record things like periods, dates, weights, and all sorts of changes, because when you're having a conversation, you don't want to just rely on, oh, I remember this. In fact, from speaking to many of my patients, it's simple conversation. When was your last menstrual period? We have that kind of conversation, when really you could just have it in your phone and you can just pull it out, and we have really useful pattern that can help us make one or two decisions. Okay, so I would recommend, please, keep a tracker. Be confident going to an appointment when you've gotten information from us, like you're getting here, and ask before, say, this is my situation, I want a risk benefit analysis for me and HRT. Here's my family history, here's my personal history, here's this, here's that. I want to understand what are my risks so that I can decide if I can go on this treatment. This is something that your doctor will be happy to have a conversation with you about. Let me know, what are you guys thinking? Okay, is this something that's been a big worry? Is this HRT business being a really big concern? Perhaps, maybe not for you yet, but maybe your mom or sister or a friend, or you've heard something actually and you think, oh, never am I ever going to go on HRT. I would love to know your thoughts, or how you feel about it. Is it something that you're going to explore as you grow older? Do you have any worries? Please drop them down in the comment section so that we can, we can sort of talk around them, have a conversation as to what is the best way for us to go. All right, let us take a quick break. And when we come back, we'll go on to the next segment. I'm enjoying the beat. Okay, guys, let us crack on. So, this was a really interesting one, because on the face of it, I hadn't considered it. And then when I thought about it, I thought that is actually a pretty decent question. So again, this is menopause. We're still on menopause, talking about related menopause issues. Oh, let me just take a quick look at chat and see. Oh gosh, okay, nobody's popping anything in. Guys, please feel free. I'm happy to take questions if you have any. At the morning session, Sonia was fantastic, providing her experience. I love it when you have people who can just come in and either confirm or challenge, or just put some insight into the conversation that we're having. I always find that really, really helpful, interesting, and really, really helpful. Anyway, let us crack on. If you're here and you're lurking but you're finding value, all I ask is please just give this video a like. If you change your mind and you want to pop a question or a comment in, please be respectful. Be mindful that we respect each other. It's a safe space here. No question is silly, but just respect. No opinion is silly, but do it in a respectful fashion. So, what is the question we're dealing with? Can you eat fruit with a urinary tract infection? I was like, where is this coming from? What's this mean? So, let me just break it down and make it a bit clearer if possible. So somebody says, if I'm prone to UTI, so if you're not prone to urine infections, this probably will not make sense to you, okay? But maybe you should just take a second and listen. So the question is, if I'm prone to urine infections, do I need to avoid fruit because of the sugar content? Now, the short answer to that is no. Let's get that off, just in case you're one of those that wants to quickly dip in and dip out. So, short answer is no. But I recommend you stay for a while and understand why. Because the real answer, okay, is referencing a clever supplement or drug. It's not new per se, but the awareness of its benefits in treating recurring UTIs is becoming more pronounced or more prominent, and that's D-mannose. So if you are in the recurrent UTI sort of subpopulation, where or every 6 weeks or 8 weeks, it's back again. You've had all sorts of tests, you've been here, done that, and they've not found anything. They've put you on preventive antibiotics. I mean, there's some women for which it's really horrendous, okay? But if you are the one asking that question, I really want to explain that we're talking about different sugars here. So we need to understand the difference between fruit sugar, okay, and processed sugar. Okay, so this relates to how bacteria behave, okay? So the bacteria, the germs that cause urine infections, mainly E. coli, they use sugar as a food source. So that's why sugar is important. I completely agree, okay? But the sugar that they're primarily feeding on is that sugar that ends up in your urine from your bloodstream. Okay, now let's talk about fruit versus added sugar. The natural sugar in a piece of fruit, so it's packaged together, so it's a combined molecule with fiber, water, nutrients. It doesn't result in the same jump or spike in your blood sugar the way a bottle of Coke or a can of Coke, that is pure Coca-Cola. I'm sorry, is there anything wrong with saying Coke? Any kind of soda, maybe that's the diplomatic way of saying it. Or orange juice, concentrate orange juice that you buy from the store that we know is packed with sugar. The real what's the word for them? The real culprits, the real people I'll blame, or the real individuals to blame in this whole scenario is highly processed foods and drinks with added sugar, because that's the one that sends sugar straight into your bloodstream. It's not going to wait to be broken down, unlike the fruit sugar. This is pushing pure glucose straight into your bloodstream, causing the spike, and then into your urine, and this is what the E. coli are looking for. So what about D-mannose? Why have I brought D-mannose into the conversation? Well, D-mannose is a simple sugar, and it's similar to glucose. Okay, so you're getting where we're going. Why D-mannose is important? It's going to deceive the body, or deceive the germ into thinking, oh, this behaves like sugar. Okay, but it's unique. So the way E. coli are structured, they have tiny hair-like attachments on their little bodies that they use to stick onto the bladder wall, which is where they hang on, firmly stick there and start multiplying to cause problem. But this hair can also bind or stick to D-mannose, okay? So when you drink a D-mannose supplement, it goes through your system and then enters your bladder like sugar does. And then the E. coli now gets stuck to it instead of sugar, okay? Or instead of glucose from processed food or from added, soda or, concentrated orange juices and stuff like that. And so because the E. coli becomes stuck to the D-mannose instead of the other type of sugar, it can be, it will be excreted. So because the drug itself as a waste product is going to be excreted, it will take along with it the germs that have stuck to it, and that's how you can get them flushed out of your system, out of your bladder. This is how this particular medication has been useful, even as effective in some studies as low-dose antibiotic at preventing recurring urinary tract infections. Please note, I preface this with recurring. Remember, I said at the beginning, are you one of those people who has recurring urine infections? And this is for you. Okay, it also has fewer side effects. It's not an antibiotic per se, so it's not even an antibiotic, so you don't have the risk of developing antibiotic resistance. But why is this an issue around menopause? Well, it's because estrogen is coming down, and that can affect the vaginal tissue, the tissues of your urinary tubes, like your urethra, that's the tube that goes out of the bladder, because the protective tissues or lining, that is the, the way you line a cake pan, or organs are lined similarly. So the protective lining thins, okay, and the natural protective germs inside the vagina actually drop. Their numbers reduce. All this because of estrogen reduction. And so that makes it easier for E. coli to cause problems in menopausal tissue. So using D-mannose is a really useful tool for somebody in that age group who suffers from recurrent urinary tract infections. But we're not saying that you should stop eating fruits. Please eat fruits. Fruits are useful sources of nutrients, including complex sugars that help your body. You need energy, contains fiber, contains water. So fruits are really important. The other thing that's useful for preventing, or if you're dealing with recurring UTIs, of course, you should be under the care of your doctor or your specialist. Drink plenty of water throughout the day to make sure that you're constantly flushing your bladder, flushing out germs from your bladder. You could have a conversation with your GP about DMANO, see what they think, see what literature there is, or with your specialist. I would recommend in your diet, consciously cut out added sugars. So cut down the sodas, the concentrated drinks, processed foods that can quickly provide or grow glucose inside our blood, but not whole fruit, which is nutritional, okay? And of course, just as an aside, if you're menopausal and you're experiencing dryness of the vagina, there are topical treatments like topical estrogen, that's like a cream or a gel that you apply in the vulvar vaginal area with a much lower risk, if at all, compared to the ones that you take by mouth or the ones that you rub on the skin. If your problem, like for many women, the menopause problem that they have is dryness down below. They don't get hot flushes, they don't get bone problems, they don't get memory fog. It's just that problem. And many run away because they think, oh, they'll come to the doctor and will say, oh, here's HRT, take it. But actually, you can have just vaginal estrogen with a lot better side effects profile. That means it's a lot safer, that you can use down below to give yourself a lot of relief from pain, from discomfort, recurrent infections, even painful sex, and so on. What do you guys think? What's been your experience? Okay. I mean, as we talk about this, I know that this is not limited to just one person or one group of people. I know there are lots of people that have this kind of experience. So please share your thoughts in the comments and let us see. Hi there, Irene. Irene Rod says, I had a polyp removal surgery. My OB/GYN told me they can recur. Should I limit dairy and soy? Now, should you limit dairy and soy, depending on how much you were taking before, as an overall health benefit? Yes, moderation is key. If you're asking me whether if you stop dairy and soy altogether, it will stop a polyp, and I don't know where this polyp was, I'm presuming it's an endometrial polyp, cervical polyp, because there are different types. If you're asking whether doing that alone will prevent the polyp from coming back, I can't tell you. There's no data that suggests that. Okay, so these kind of tissues, polyps, are likely under the growth of or the control of hormone imbalances most of the time that they happen. So if we're looking at how to prevent them from developing, I completely support an overall balanced diet, so that if you're cutting down certain types of dairy like cow's milk, if you're cutting down soy, that's reasonable as an overall health action, as an overall health target. The data when it comes to soy and the effect on estrogen, because I know that's where you're going, is a bit conflicted at the moment, because we have studies that give us different results. There's a group of studies where it says that yes, taking soy increases estrogen. I mean, this is looking at studies on different gynecological problems, from fibroids and the rest. And then there are other studies that say actually there is no change, or that is even beneficial for people with fibroids. So we can't say clearly, and that's why your doctor will not, I don't know if you ask your doctor, but that's why they will not say this is a recommendation, definitely cut out dairy, definitely cut out soy, and you will never be troubled with polyps before. Nobody's going to say that, because we don't have the data to suggest that. But I will definitely support that if you look at your overall health. Cutting down dairy, for example, cow's milk might increase the amount of fat and cholesterol. So if you're looking at a healthier option, perhaps a plant-based milk, if you're looking at what is going to be healthier overall, and I'm talking about things like almond milk or oat milk, for instance, and then eating soy in moderation. If it's something that you like eating in moderation, so not frequently, then that's no wrong way to go. I think that would make a lot of sense. But I definitely wouldn't say to you definitively that if you stopped dairy, stopped yogurt, stopped all that, no more soy, then definitely the polyp will not grow again. No, I don't think it's so. I don't think it's so simple. We say hormones, but there may be other factors, even genetic factors, resulting in why some people are more likely to develop endometrial or cervical polyps compared to others. But thank you so much for that question. I think it was a really interesting one, really insightful. All right, guys, thank you so much for watching. Don't forget to give this video a like. We've just been tackling the issue of whether if I have recurrent UTIs, should I avoid fruit altogether? Because the worry is that if you have recurrent UTIs, sugar increases the germ, the E. coli germ. The presence of sugar in your body can make them multiply quicker, faster. And so we've just been explaining that the sugar that you should be particularly concerned about, and I've explained the process, is not fruit sugar, which is a complex mix with fiber and water and all that. Is the sugar, the simple sugar that is found in processed food, different types of soda. And then I explained the antidote, if you like, that we have to that problem, which is the supplement D-mannose. So if you're just coming in and that's an interesting point and you want to learn more about it, please watch the replay. Let's just take a quick break, a quick message, and then I will get on with the rest of the stream. Are you tired of these women spend years struggling to be heard? I'm Dr. Sylvia, a GP and women's health specialist with 15 years of experience working with women just like you. I provide private consultations to thoroughly investigate your symptoms, create a working diagnosis, and map a personalized treatment plan so you can get back to living your life. We can explore unexplained period pain and heavy bleeding problems, suspected or managed endometriosis or adenomyosis, polycystic ovary syndrome PCOS, fertility awareness and preconception advice. So what can you expect? Initially, we'll have a 30-minute consultation where you are the focus. We will review your history in detail, discuss potential next steps like scans, blood tests, or a referral, and create a clear plan for your relief. So what are you waiting for? Click the link in the description box below or in my bio, or just visit your gpconsultation.com to book your women's health assessment now. Are you tired of being told your debilitating pain is normal? You're not alone. Many women spend years struggling to be heard. I'm Dr. Sylvia, a GP and women's health specialist with 15 years. Okay, welcome back. So we are looking at the very, very next topic, and this is around fertility. And yeah, it came as a question, and of course, it's a very sensitive one. And I always like to encourage us to have conversations here on this channel. So I would love to hear what you guys think about this. What would you say to a couple? But you know, we're focusing on the woman, but it's not just women; it's a couple thing. But what would you be saying to a couple experiencing, or perhaps just on the very early path of the fertility journey, which can be different for different people and can have different complications? So that's the conversation that we're having now. I would love to hear your thoughts. And you know, when I say what kind of things, I'm looking at, you know, practical things, day-to-day life, practical things that people get into or people experience along the fertility journey that makes it all the more overwhelming, and how can they navigate it safely, navigate it with minimal challenges. So like I said, it came up as a question. I have some thoughts I'd like to share with you guys and see what you think. I feel when a couple is struggling to conceive, it can feel isolating. Imagine a group of friends from uni, you got out of school, got into work, and you know your mind is about starting a family, and then out of the bunch of 6 of you, for example, who are now in married or in steady relationships, perhaps you're the one who hasn't had your baby shower, you haven't had a kid, and you know, these are key milestones that can be so significant. Some of us might just take it as a matter of course, part of our social life. But for some people, going through fertility challenges can be so overwhelming and emotionally draining. A complex journey, but how can we make the approach simpler for people to navigate? So I'm thinking about a very clear roadmap for those first steps, because everyone's journey is different, okay? So I think the key thing first is to acknowledge the grief between yourselves as a couple. Don't bottle it up. Okay, so I'm tackling first the emotional aspect, then the logistics, and then the medical. So I think it's to acknowledge the disappointment every month, month after month. There's hope that something is going to happen this month, and then disappointment. That's a form of grief, and it's important to acknowledge that you're going through that situation. Can be life changing for many people. So there's that sadness and frustration, even anger. And that's a natural, normal response to a very, very difficult situation. Okay, then the other thing I would say is intentionally be proactive about protecting your peace. Don't joke with it, okay? Now, this might mean doing drastic things. It might mean archiving some chats on your social media, muting some social media accounts of people, even those that you know with newborns, skipping baby showers, or just setting boundaries. There might be some people who, yeah, maybe just not thinking well, not being empathetic or not being emotionally mature enough to be careful in what they say or being sensitive about what they say. So you might need to set boundaries and do those things to protect your mental health so that you don't go into that spiral that's hard to come back from because of some careless comment or because, oh, somebody's doing that over there. You know, we're all different. And if you can sort of put yourself in a safe space and actually put yourself in the group of supportive people. And I'm not saying that friends or family who say these things are intentionally wishing you bad. No, it's just that that's not the space that you need at this time. It's not helpful. And it's about dealing with it in a positive, proactive way. And the last thing I'll say in terms of emotional support is about consider joining a dedicated support group. That is people who have also been on the same journey, or people who know, who are trained or experienced in counseling those who have been on that same journey. It could be in person, it could be online forums or groups, you know, but they are the ones who understand or can empathize with the scenario, with the situation that you're going through, with the isolation, and they can provide some validation. Sometimes that's really much needed, and that can help you take the next step, help you get the next month or the next couple of months that you need to along the journey. Okay, the next thing is the medical aspect, and I just want to talk about basic tests because it can all seem very, very overwhelming. So just basic, right? First, it's a couple thing. It's not one person. Okay, I know the topic. I know on my screen is saying essential wisdom for women because we're a women's health channel, but it's a couple thing. So tests, so support and counseling for both men and women. But of course, you know that women are the ones carrying the baby, the ones going through the periods and looking for a positive pregnancy test and so on. So it's a couple thing, yes, but there is that greater share of the ache, that is the burden that is carried by the woman. Anyway, let me crack on. So infertility, I'm saying, is not just a female problem, okay? We have to look at both partners right from the start. Remember that when we're looking at causes of infertility, it's split in roughly 3 equal parts as far as we know. A third is female related issues. Another third is male related issues. Then there's another third for both of them, or causes that we don't really know or cannot explain. Okay, so what about the tests? Okay, so first of all, for you, the lady, you're going to have blood tests that will look at your ovarian, what your ovaries are doing, what your eggs are doing, how many eggs do you have, how healthy is your ovary, what's the quality of eggs. So that will involve doing blood tests. So you might hear of a day 3 FSH or AMH blood test. You have an ultrasound. An ultrasound is kind of the pelvis, and that's looking at the ovaries closely to look at what your antral follicles, that's your ovarian follicles, are doing. So those are some examples of blood tests that you will do. You might have you will have a 21-day progesterone. Again, that's confirming whether you're ovulating. So we're looking at your ovaries to see whether what eggs you have, how many they are. We're looking at how your ovary works, and then we're looking at if you're ovulating. So that's a 21-day progesterone. You could have other tests like an HSG or other tests just to assess how your tubes are, whether your tubes are working properly. These are just examples of the initial workup tests to determine what exactly is the challenge. And then, of course, for the man, you have a semen analysis. And this is a test that, just exactly as it says, it's exploring your semen. So it's not invasive, but it's a really, really important test. One of the first ones actually that should be done, because it tells us about the sperm count. It tells us about how the quality of sperm, are they moving properly, and the shape of the sperm, are they healthy? All this is important key information. So again, this is targeted towards people very early on in the journey. It's not easy, and it's not predictable. Some people might have several rounds of treatment, or need several rounds of treatment if they go down the route of IVF. Some people might just need a couple. It's not predictable. Everybody or every couple has a different journey or story to tell, but there's some common threads. And I think managing your emotions, gaining knowledge about the different tests that you need to have is really important. Okay, so organize yourself. That would be my sort of last batch of tips. Get yourself organized. There's a lot of information that people are going to be throwing at you. Get your results, appointments, put them in one place, get things filed away so that you can easily refer to them as and when needed. And then get yourself ready for having the conversation. Don't leave it too long. There's a video I have, I can't remember what it's called now, but I was specifically looking at when you should be speaking to your doctor about fertility issues. So we say that the rule of thumb, if you like, is that if a couple have been having unprotected intercourse 3 times a week for 12 months, then and no pregnancy has happened, then we would consider infertility. We would consider investigating for infertility, especially, if you're under the age of 35. So we're saying that within 12 months, any ordinary healthy couple having sex at least 3 times a week for 12 months should fall pregnant. And so if that is not happening, then you now begin to ask yourself what's going on. So like I said, if you are a couple, ordinary healthy, no problems, then, and you've had that number of sexual encounters for 12 months, you should go and speak to your doctor. Now, if you're over the age of 35, okay, either of you over the age of 35, then we would say 6 months. Give that 3 times a week timing for 6 months. If you have health conditions like fibroids, for example, endometriosis, don't wait 6 months or 1 week. Go and sit down and have a conversation about your fertility, because that should be part and parcel with your treatment of this condition, because we know it impacts fertility. I have that video somewhere where I break this thing down a lot better, a lot more succinctly. If I remember, I will put it in the links for this video. So these are just pointers to when you should see your GP or when you should see a specialist, okay? When to have those first series of tests, those simple tests, and how to protect yourself so that you are not in a situation going through the challenge of having these tests, the challenge of having these conversations, the challenge of experiencing the disappointments and the mental toll that it takes, and then also dealing with cultural expectations or family expectations or expectations from friends. And again, I'm not saying that anybody is intentionally being bad. It may just be that it is being thoughtless. Okay. All right, guys, let me know what you think. What is your experience of this? Where have you had issues? This is a sensitive one. So I know that people might have different, thoughts of how to go about this. I totally appreciate that. But yeah, if you're watching the replay and you have any thoughts on this, please let us know. Okay, let us crack on, guys. Let us get cracking. I'm loving the fact that we're making a lot of progress on these different topics, and I would love to know what you guys think as well about about this format of streams. I'm hoping I can get to them a lot more often. But yeah, let's take a quick break. I'll be back with you in a moment. Okay, welcome back, welcome back, welcome back. We are moving on. Ovarian cysts. What does this make you think about? Ovarian cyst. What comes to your mind? Let me know. What is it that comes to your mind, when you hear ovarian cyst? Are you thinking about a scan? Are you thinking about pain? Are you worried about cancer? What does, when you hear ovarian cyst, what is it what comes readily to mind? I want to talk about this because, of course, there was a question that came around ovarian cyst and somebody concerned about the risk of cancer, and I thought it was nice to provide a little bit of just this little explanation, simple explanation, okay, about this, what ovarian cysts are, what to expect. Okay, so when you hear ovarian cyst, don't immediately rush to cancer, because an ovarian cyst is not ovarian cancer. Okay, the vast majority of ovarian cysts are harmless, even a sign that your body is functioning normally. So let's break it down. So you have the everyday cysts. The ovary itself is full of cysts. Okay, so we have the, should I say, good cysts, or we call them the functional cysts. They happen because of the function of the ovary. That's the best way to remember them. They are a normal part of a woman's menstrual cycle. Your ovaries aren't just, well, all of the organs, there's always some activity going on, even the skin that looks as if it's static. There's cell division, your hair is being produced, you're shedding skin, there's always activity. The ovaries, how much more the ovaries? The ovaries are dynamic organs. Every month they grow a small cyst or follicle every single month. That job is happening in the ovaries. That is if you're premenopausal. Okay, if the follicle grows but it doesn't release an egg, okay, at the end of that cycle, that follicle becomes filled with fluid and becomes a cyst, basically. If, on the other hand, that follicle releases an egg, after the egg exits the follicle, it's empty now, so it becomes something called a corpus luteum cyst, and then just becomes filled with fluid and it's sealed. So these are two types of functional cysts. And just to say to you that cysts are happening all the time, it's a normal part of what's going on in the way your body is dealing with different events inside the ovaries. They're almost always benign, i.e. harmless. Often they will cause no symptoms and generally will get better. So you might have a cyst and they might detect it on a scan. So you might go for a scan for something, and then, when the report comes, they say, they saw a cyst on the ovary, and you're worried, oh my goodness, what does this mean? And then the doctor just says, come back and we'll do the scan in 3 months. A standard response for a simple cyst that its size doesn't cause any concerns. And then when you come back in 3 months, it's disappeared exactly as expected, because generally the body will resolve cysts like this, functional cysts, within 1 to 3 months. And that's how we treat them. And they just indicate that your ovary is doing what it's supposed to be doing. Okay, on the other hand, okay, we have cysts that are not benign. Okay, we call them pathological cysts. They don't develop along the line of a normal menstrual cycle, and they can happen because of abnormal cell growth. Okay, now they are less common. Some of them are usually benign. Okay, so the reason we say they're not functional is because they're not happening from the normal menstrual cycle happenings. So you might hear things like dermoid cysts, which are funny, rare type of cysts where you have different types of tissue like hair, yes, in the ovary, or teeth. Yeah, as a medical student, that was one of the most interesting times. I think we had a specimen in my school then that you could look at. This is from the ovary and it has teeth and bone. And it's simply because they're coming from the embryonic cells when we're developing. Okay, so there was something happened along the line, and so tissue that was eventually going to become hair and bone and teeth found itself within the ovarian tissue. So that's one example of a pathological cyst, but it is benign. It's not really going to cause any harm. There are other cysts like a cystadenoma, which is a type of cyst that develops on the top of the ovary, the surface of the ovary, and it might contain water or mucus, and generally it's one of those cysts that grows quite large. So if you remember the name cystadenoma, the way I remember it is long name and big size. Anyway, again, it's an abnormally growing cyst, but it's benign. It's not cancer. And what you need to keep track of is the size, because of course the size can be a problem if it's growing in the pelvis, which is, you know, a limited space. So that's another example of a pathological cyst. It's not functional, but then again, it is benign. But the problem is when it's with its size. And then, of course, there's something else, another example, and there are different examples of different cysts, but I'm not going to go into too much detail just for the sake of our conversation here, is the one that forms because of endometriosis. And we call those endometriomas. You might have heard of them as chocolate cysts because they contain blood, usually old blood, that gives them a brownish chocolate-like appearance, and they are because you have endometriosis or endometriosis lesions on the ovaries. Don't forget that endometriosis is a condition where you have tissue that is normally lining the womb developing outside the womb, anywhere. It could happen anywhere. So anywhere in the pelvis, example, the ovaries, even outside the pelvis, it could happen. Okay, so overview, different types of cysts, so that when you're thinking about cysts, you have this kind of structure in your head. When should you worry? Okay, I think the main thing about ovarian cysts is not actually cancer, it's just about the complications of the cysts. Okay, functional cysts, like I've said to you, many of them will resorb, they'll shrink back and the ovary carries on doing its job. But sometimes cysts can burst and they can cause sudden sharp pain. Okay, they can cause a sudden sharp pain. That is what sometimes brings ladies to the emergency department with severe pain in the pelvis, just started suddenly, low down there. And sometimes, you know, that can be managed, but sometimes it can cause a lot of bleeding and requires urgent medical attention. The other thing that can happen with a cyst is it can twist on itself. That's called an ovarian torsion. It's a medical emergency, because when a twist does that, when a cyst grows so large that it causes the ovary to twist on itself, it can cut off the supply, the blood supply or the circulation to the ovary, which is a dangerous thing because that leads to the death of that ovary. So something else that could happen with the cyst is as it grows, it might position itself in such a way that it causes the ovary to twist on itself and then leads to compromise of its circulation. And the symptom with that is also a sudden, severe, one-sided pelvic pain. Doesn't get better, it's a severe pain. You might feel sick or vomit. It's a medical emergency, and it requires immediate hospital care, admission for scans, intravenous fluids, surgery for that. So please bear that in mind. Cancerous cysts of the ovary, they are rare. They're not saying they can't happen, they are rare. So you might have cysts that are complex cysts that can develop. It's a cyst that is not disappearing after you come back after 2 months or 3 months. That's the cyst that, you know, your gynecologist will want to pay attention to because it's not disappeared the way it should do. Or if it's getting bigger and bigger, or women after the menopause are developing cysts. So please don't panic. You've had a scan and they said, oh, they found a cyst. Okay, so you need to say to them what type of cyst is it so that you have the right frame of mind. And then, you know the treatment. The doctor is going to tell you the treatment based on these categories I've just provided. Emergency symptoms: sudden, severe pain, one side, emergency room. I mean, there's so many other things that it could be as well: an appendix, inflamed appendix, ectopic pregnancy, kidney stone, ovarian cyst is one of them. So those are reasons, emergency reasons to be in the hospital. So I don't want you worried, oh, is it a cyst or is it not a cyst? No. Sudden, severe pain, not letting you do anything, even vomiting, nausea with it, feeling unwell, you can't stand upright, hospital, emergency assessment. Okay. And follow up. Follow up is important. If they say to you, you need to have a scan in 3 months, please put it in your diary. If they've not sent an appointment, chase after the appointment. You need to have a follow up. Okay, please have that in the back of your mind. So this is how ovarian cysts function. This is what they are. This is just a very quick run through what ovarian cysts look like. I hope that's been helpful. Please let me know. Again, let me just have a quick look in the chat to see if anybody's commenting on that. I'm wanting to know. I don't know what Irene, she sent in that question. I think she maybe have popped off, but anyway, no further questions on that. But if you have one in the replay or when I split these videos, please let me know, and then we can obviously look at doing a more detailed dive into ovarian cysts or other ovarian issues. Okay, I wanted to play my other the other video where I've got for your GP consultation, because I had the one on period pain queued up, but there's other. I hope it plays properly because I was having challenges with that one. Let's see what it does now. I'll leave that with you for a second, and then we can come back to discuss the next. We can come back to discuss the next questions. Are you feeling I change hot brain fog, sleep problems, and for many women, a loss of confidence? Hi, I'm Dr. Sylvia, a GP and women's health specialist with 15 years of experience working with women just like you. I offer expert guidance and evidence-based treatment to help you understand your symptoms and find an effective path forward, including HRT and non-HRT options for treating your symptoms. We can address managing perimenopause and menopause symptoms, hormone replacement therapy, HRT consultations and prescriptions, or explore alternative treatment options. We can also look at mental health, brain fog, and low mood. Something else I explore are sleep issues and low energy. So if you book an appointment, what should you expect? Well, initially a 45-minute consultation dedicated to you. We'll untangle your symptoms, discuss the pros and cons of all the treatment options, and then create a personalized management plan to help you feel like yourself again. So, what are you waiting for? Click the link in the description box for this video or in my bio, or just visit yourgpconsultation.com to book your menopause consultation. Are you feeling overwhelmed by changing hormones? Perimenopause is more than hot flushes. It's anxiety, brain fog, sleep problems, and for many women, a loss of confidence. Hi, I'm Dr. Sylvia, a GP and women's health specialist with 15 years of experience working with women just like you. I offer Okay, thank you so much for sticking with me. And we're doing an extensive deep dive into women's health problems. And I'm really pleased that we've covered such a large range of different questions, topics in today's live stream. And I'm really keen to do something like this. Maybe we'll do it on a monthly basis. But anyway, I'd love to hear your thoughts. So what are we talking about now? Is your birth control making you feel worse? I feel as if I'm shooting myself in the foot by asking that question. But I think it's a valid question to ask, and it's not a laughing matter. I think it's really, what's the word now? It's not very good, is it? It's distressing if you're taking a pill to help you focus on things that are important for a period in your life where you don't want to have an unplanned pregnancy, which is an important part of life, but you want it at a time when you can fully focus on it and devote the amount of resources, both mental, physical, and so on. So when you're taking birth control to achieve that purpose, but it's now causing you problems, I think that's where we have the challenge. That's where we have the difficulty that many women experience. So again, I would love to hear from you. What is your experience? Have you felt that since starting birth control, you haven't just felt like yourself? Okay, maybe your mood is lower, maybe you're more anxious, or maybe your sex drive, your libido has just tanked, just gone. You go and have a conversation with your doctor, but they're a bit dismissive. Okay, so that's not very good. But this experience is real, and there is a scientific reason for it. It's not something that we shy away from. There is evidence that in some women there could be some effect on libido. We do acknowledge that, but it's similar to an example I gave earlier, that we have different makeup, if you like, genetic makeup, and so something might affect somebody in one particular way. The next person using exactly the same drug may not experience the same. So it's good to bear that in mind. And I did say that sometimes when you come to see your doctor, we have this in the back of our minds that it may be a different drug will suit you. And especially these days that we have different formulations, okay? So again, we're talking about something called neurotransmitters. These feelings are not in your head. We know that the drugs in the birth control, the hormones in the birth control, the human-made hormones, especially progestin, can influence the brain chemistry, reducing the activity of chemicals like serotonin, which is really important in mood, making you feel happy, making you feel upbeat. And so the effect of the birth control hormone on some people could lead to feelings of depression or irritability. We know it could also affect with the calming chemical or calming hormone GABA, which helps, to keep you calm and sort of, serene, if you like. And when that chemical is blocked by the birth control, the progestin in the birth control, it could lead to increased problems with anxiety or even disrupt sleep. So growing bodies of research are telling us that women on these birth control pills could have different structure or way that they respond to this, that their bodies respond to stress compared to people who are not on the birth control pill. So we're seeing this more and more in data. So I want to reassure you that if your doctor is dismissive or they feel that you're not really making sense or they're not doing anything proactive to help you with this problem, I want you to encourage you that yes, we are seeing this as a real thing and there is help. Okay, there is help. Now, birth control works by, what does it do? Suppresses your body's production of hormones, okay, including testosterone. So this is how it can affect the libido for some women. Of course, women produce less testosterone than men, but it is still crucial in driving the sex drive for both men and women, okay? And so if it's very low, if it's suppressed significantly, it can affect your sex drive. So the loss of libido can then create stress in the relationship, which then further impacts your mental health and is a vicious cycle, isn't it? I would recommend, okay, that you're tracking your experience, tracking your symptoms. Don't just depend on memory. Please make a note of what exactly is going on, your experience. For 2 months, 6 weeks, 8 weeks. 8 weeks would be great. Keep a simple diary, rate your mood, your anxiety, energy, sex drive. And this will give you objective information because you can say, for the months between February and March, this was my experience. And you can use that to have a conversation with your doctor that would put you in a forward path. You're not just in one place, you're moving forward. And then the other thing to say, I just mentioned that, is we've got different pill formulations, okay? There's some that are more androgenic, so they're more testosterone-like, okay, while others are less testosterone-like. So switching the type could make a world of difference for some women. So you might want to have that conversation with your doctor. Do you think this pill that I'm on is more androgenic and that I might be better off switching to one that is less androgenic? So those are the kind of things that your doctor will consider as well, okay? And then, of course, there's still always the option of non-hormonal methods of contraception if you're struggling with a hormone based one, and that's still an option, because I think the key thing is not feeling as if, oh, there's nothing that's going to work, or feeling as if you're anti this drug because it's the drug companies that are just meant to do damage and so on. I think it's about having a reasonable conversation, expressing your preference. If you don't want to be on birth control, on hormonal birth control, that's fine, as a preference, as a choice. If you do, but you're worried about misinformation, hearing stories that are not backed by evidence, then I hope this conversation here helps you change your mind and helps you move in the direction that you need to get, the help that you definitely deserve. So please speak to your doctor. Let me know what you think. Let me know what your experience is. If you try to speak to your doctor about your pill affecting your mental health, or affecting your libido, your sex drive, and you were just brushed off, please let me know your thoughts, how that happened, how that worked out, and what you did, how it got resolved. You might, need to explore things like booking a double appointment, so it's not something that is rushed. You can have a nice proper conversation. And then, like I said, if you're based in the United Kingdom, your gpconsultation.com, this is an area that I'm experienced in having conversations around and guiding people to move to a method that's more suitable. So please use the link in the description box to get in touch, and we can hopefully take things forward for you. Marvelous. Okay, let us move on, and then we'll go to the next question. I think I had a poll I wanted to share with you guys. The problem is I'm not sure about sharing my screen. I couldn't do it very properly in the morning, so I don't think it's going to work this time around, but I'll see. right, guys, welcome back. So we are looking at. I'm just laughing because I thought I covered all the pregnancy-related. I thought I covered all the pregnancy-related conversations earlier. Oh, yeah, and this one just sneaked past me. I think so. This is navigating the first few days the first day postpartum. No stitches guide. So you've not had a cut, you've not had a tear, no stitches, and we're just talking about how you navigate the first day postpartum. Okay, so I think it's interesting because again, I just feel, especially if it's the first time, first baby, still a lot of unknowns, things that you're not sure how this works or why this happens and so on. I feel these are the kind of people that will really benefit from this conversation. So again, if you're here watching the replay, let me know. Let me know what your experience has been in this kind of a thing. What were you told? What did you expect? Or if you've just had a baby, actually, maybe you're in the first 12 months, just had a baby, what was your experience? You've just had a vaginal birth, not needed stitches. That in itself is an achievement. But yeah, your body has been through a lot. So knowing what to expect on that first day can make a difference. Honestly, can make a difference. Many of us have moms. I didn't have my mom to tell me what to expect. So it was really a foundation. It was really many new things to pick up, even with my training. And, I think that there could be many people like that. Sometimes just knowing what to expect would be really useful. So, of course, the first few hours, first thing is, of course, the after pains. You're going to experience pains, period-like cramps. Now, this is your womb is shrinking back into its pre-pregnancy size. Now, those cramps can be quite intense, especially while you're breastfeeding. Because while you're breastfeeding, the hormone that your breastfeeding stimulates or releases, called oxytocin, also makes your womb contract. So it's a good sign that your body is doing what it's supposed to be doing. It's just that it's a painful sign. The other thing that will happen is your bleeding, something called lochia. We call it lochia. So it's not a period blood per se, but it's the womb emptying itself from everything to do with birth. Okay, because of course the babies come out, the placentas come out, there's still material left behind in the womb that's going to come out. So you can expect the first few hours some heavy period-like bleeding with some small clots, and that's normal. So it'll be a bit heavy, like a period, not intense, not flooding, gushing blood. That's not normal, but like a period with some small clots, less than a pound size. That is not unusual as you're having this cramping, your womb is emptying itself. If you're not sure, ask the nurse or ask your midwife, whoever's looking after you, or your doctor. Usually the heavy duty maternity sanitary towels are usually, the best to help manage that. Passing urine, really important. Okay, really important that you must try to pass urine within the first 4 to 6 hours after you've had the baby. Okay, now, if you've been part of the entire streams I've done today, I've been banging on about, especially if you are the first one where we talked a lot about pregnancy and post-pregnancy situations. Drinking water, drink water. This is why it's important. Don't forget that the bladder has been squashed by the big bump for many months now. Okay, it's been squashed out of the way, which is why you've been going to the toilet so often to pass urine. So now the bladder is going to sort of relax back into its normal state, and so we want to make sure that it's doing what it should do. If you have a full bladder because you're not able to go, that can cause bleeding and pain. It can cause irritation of the womb behind. So take your time, but be conscious of the fact that you do need to keep track of your urine. You do need to pass urine. Make sure you're taking plenty of fluids. Of course, you might feel uncomfortable down in your vulva because as you were delivering the baby's head was pressing hard while you were doing all the pushing and bringing the baby out. The baby's head was pressing against the sensitive tissues of your vulva. So those are sore. Trying to pass urine through those sore tissues can be quite uncomfortable. It might mean that you're sitting and sprinkling water against your sore tissues while you try to urinate. That can dilute the urine, make it a bit less acidic or stingy, and just help with the sensation. If you can just get the first one done, then the subsequent ones will be easier. Okay, then of course the next thing to think about is the swelling and the discomfort. I've just mentioned that even without a tear, without a cut, that area around your vulva and your perineum, so that is the vulva and the area in between your anus and the vulva, all that skin, all those tissues, the perineal area, all that has been stretched and really squeezed, compressed to its absolute limit to help baby's head come through that space. So there is bruising, there is swelling, okay, that's normal, that's expected, it will settle down. What can help? Sometimes ice packs, some hospitals or clinics will provide you with an ice pack, or you can get some that you can apply over your sanitary towel. So especially for that purpose, maybe for about 10-15 minutes at a time, just to numb the pain and the discomfort. And with time, it does settle down. Okay, you're advised to rest as much as possible, especially the first 48 hours. Your business is in resting and recovery, feeding your baby, eating, sleeping, rest and recovery, feeding your baby, rinse and repeat, rinse and repeat, rinse and repeat. Doing all of that would help to heal that perineum, that perineal area I was talking about. Something else that can be useful, maybe the third, fourth day, or even by the second day, if you're up to it, is, and when you're back home, is having a warm, not hot, warm sitz bath. Okay, so that's like a bath that you can sit in. There are lots of them on, you can buy from Amazon, from the shops, that you can just sit in. Some you can put a little bit of salt, or there's some you can put some infusions just to help. The warmth alone just helps to promote blood flow, promote healing. So that's something that you might use. Definitely for someone who's had a cut or sustained a tear and they've stitched it up, sitz bath can also help with the pain, with helping blood flow and different, those different areas that need recovery. Now, moving around. How soon can you move around? Remember, this is a vaginal birth, no tears or cuts you're talking about. So start slow, pace yourself. You're not in a marathon, you're not competing with anybody. Start slow, okay? Like I said, the first couple of days, the first 2 days, you're resting, you're recovering. But by the the third day, for example, you're getting out of bed. As you get out of bed, sit, don't just jump up, because you probably drop back down very quickly. You might feel very dizzy. So do it gradually, okay? Rest a little bit, move up carefully. Your tissues are still very sensitive. You have been through a lot. So your blood pressure differences, there's a big difference in blood pressure between when you were pregnant and now that you're no longer pregnant. So take it easy, take it easy. Really important to focus on bonding with your baby and skin to skin contact. That is whether or not you're breastfeeding. If you're breastfeeding, fine. If you're formula feeding, fine. Do the same. Bonding with your baby, skin to skin contact is what we're talking about. That helps regulate the baby's temperature as well. And that's why as soon as baby is out, they pop the baby on your body, so that your skin temperature and contact already begins to support the baby. And of course, encourages breastfeeding if you're going to make that choice or go down that route. You have to be proactive. You don't feel under pressure to entertain visitors. You don't have to see or speak to anybody until you're ready, okay? And, that includes very close friends or family. And believe me, they will understand. But the most important at this point in time is your baby and your own health, both physical and mental health. So drinking plenty of fluids, resting in bed. You might have a side pillow just to keep comfortable. You might find lying on the side is more comfortable. And with a pillow in between your legs being more comfortable. Use a spray or little bottle with water when you use the toilet to pass urine. And then those ice packs can be really valuable just for a few minutes against your sore, bruised tissues. Just those first few hours, you find that you're less likely to need them as time progresses. So an amazing job that you've done. Please make sure that you are using every bit of help that you're offered from close family, for cooking, for looking after other kids, for getting all sorts of things together. That would really help, get you the best that you can do. Okay, guys, I think we have covered as much as I wanted to cover on this subject. Thank you so much for watching. And let me know if you're finding this useful as well. Let us this is where I wanted to share the poll, but I can't do it because I think it might just take the stream off. So next time I'll have that ready. I'll work out how we can do it. I feel if we try to do it now, I'm not sure what might happen. Let me see. Okay, let me just see. Let's see. Okay, let's see. Okay, so it's YouTube. So what I'm trying to do is show you one of my YouTube polls. I hope it works. Okay, so this is a poll that we did a couple of weeks ago. We're looking at breast cancer. Okay, let me see. So I've got it up here. Let me see if it'll show and if you guys can see. So I remember somebody asking me once, what are the results from the polls I run? Because she said I don't share the results. And I actually thought that's a very good point. I get really interesting results from the polls that we run. So I just want to share that with you. Oh, it's not bringing it up. Hang on. The YouTube page. It's not that one. Okay, it's not that one. I think when I tested this before, it did work for a short period of time, and then I'm just trying to remember what I had to do. No, it's not this page. If I'm going to close this window, so let me close that window now. There has to be a way that it will let me bring this up. It's not that one. So I'm trying to bring up this window. It's not opening there. Okay. Oh, yes. Oh, okay. Now let me see. Oh, I hope it works. poll. But yeah, let's move on to the next. Let's move on to the next one. Hi, I'm live, but come in. What's up? Huh? Really? You want to answer it? Yeah? Okay, guys, give me a second. I'll be back with you in 2 seconds. Let me just. All right, so we are. Oh, hang on. Oh, yes. Okay. So we're back now, and we are on. You can see. Yes, I've been waiting for this topic. Ever since I heard this topic at the beginning, I've been so interested in this topic. It's on bacterial vaginosis. And the question is, what is it now? Have you ever gotten bacterial vaginosis without sex? This room is getting a bit colder. Okay, so okay. So yeah, that's it. So have you ever experienced bacterial vaginosis without sex? So I came across this question on a Reddit poll, actually. Very, very interesting question. And even more interesting was the conversation around it, because instead of being supportive, and a lot of it was supportive, don't get me wrong, but there were some aspects of the conversation that were less than positive, and for no reason I can explain, apart from people can be just very thoughtless. Okay, but let's have this conversation here, because I always say to myself, if somebody is asking this question in one place, the world is a huge arena, so there's somewhere else that they're asking the same question. So have you ever been diagnosed with bacterial vaginosis and you've been confused, even feeling a bit stigmatized because you've not been sexually active, but you've heard that, oh, it happens because of sexual activity? So if you've ever felt that way, you're not alone. So let us try and clear this misconception up. The truth is that you can definitely get bacterial vaginosis without having sex. Okay, so let's look at how that happens so that you're, armed with the right information. What is BV? What is bacterial vaginosis? So first thing to understand is that it's not a classic infection. It's happening because of an imbalance of the natural germ that lives inside our bodies, inside the vagina. So the vagina is like a garden. Let's think about it that way, or an ecosystem that you need to balance acid and base. Okay, it's naturally populated with different types of germs, mainly the good ones. We call them lactobacilli, and what they do is they produce lactic acid, which helps to keep the vaginal environment slightly acidic. So the reason I said it's a garden is because it's an ecosystem. I think ecosystem is a better word. It's like a little community where you have germs, and they are doing, I know we say germs as if it's a bad word, but these are good germs whose activity is producing or providing some protection to the vagina by way of the lactic acid. So bacterial vaginosis is not something that you catch. You don't catch it from someone else the way you catch a classic sexual infection. It's actually somehow the shift goes from a large number of the good bacteria to a large number of the bad bacteria, and that is what causes a problem. So when the population, the balance of germs changes from more of the good ones that are doing useful things to the bad ones, allows the bad ones to overgrow, that's where the problem happens. One of the key bad guys, is called Gardnerella vaginalis. And so it's one of the germs implicated in BV. And what makes it a very special drug or germ is because it can create a sticky film, a sticky layer over the vaginal wall, which then shelters other germs and makes it much more difficult to treat the imbalance. Okay, so because the germ is not being introduced into you from someone else, it's actually the germ inside your own body that is overgrowing. That's what is special about BV. Okay, so what causes this imbalance? There are a few things, we say to women who get BV frequently, we say to them, BV is more likely to happen due to fluctuations in your menstrual cycle, or after you just had a baby, or around perimenopause. These are times when there's a change in that acid balance, because your period, for example, can introduce blood into your vagina, which has a neutral pH. And so that temporarily affects how acidic the vagina itself is, and that might cause BV to develop, okay? Other things that can make you more at risk of developing BV are smoking. So chemicals from smoking, they can get pushed or secreted into the vaginal fluid, and then they can damage those protective germs, the lactobacilli that make the lactic acid. Something else is IUD, the coil, okay? The presence of a coil can sometimes make it easier for that biofilm, that film that's produced by the body on its surface. And so that's a reservoir for those germs around the coil. So that's something else to be aware of. Another thing, and I'm always telling you guys about douching. I know some of you think, oh, it doesn't affect me. Douching can wash away those protective germs. That's a simple way to cause that dysbiosis, that disbalance between good germs and the bad ones. So, medical recommendation, do not douche. And then something else is your genetics, okay? Your makeup, your genetic makeup. Some women's body, some women's vagina just simply have a less robust strain. Can I use that term? Less robust strain of the protective lactobacilli. So they're more prone to imbalance for reasons we don't know. It's just their genetic makeup. Anyway, so BV happens. We have antibiotics to treat it. Most women are okay, but there's a large number of women where it keeps coming back. It's painful. BV is something that causes a copious amount of thin vaginal discharge with a fishy odor. It is distressing. It's uncomfortable. It's uncomfortable. It's a pain. So imagine this happening over and over again. Every few weeks, you're back again with the symptom. Many women struggle with recurrent BV. And before, we didn't really understand what was going on. It was difficult to understand what is the situation. But one of the ways to understand it is now that we're realizing that it's not a sexually transmitted infection. And it's really important for you to know that we do not class BV as an STI, but there's some ways that you might think, oh, but doesn't it behave like an STI? Let me explain. Men don't get BV. I mean, think about it. Men don't have vaginas, okay? But the germ that is overgrown and responsible for BV can move on to your male partner's tissues and hang around the skin of the penis, and then sort of reside there, because remember, they make that sticky film that can help them to stick to tissue. And so they go on, they transfer onto the men. They don't infect the men or cause any problems. Then when you have sex again, transfers back to you. You see how that can be a problem. Okay, and again, the germ is not even carried in the men's sexual tissue, in the semen. Okay, so it's really a transfer problem. It's like transferring from one, when the tissues are rubbing together, transferring from one to the next. So it's not going into the man's tissue to grow there and multiply there. It's sort of hanging around the surface of the penis or the skin around the area, so that next time there's sex, it will transfer back to the woman where it can cause the problem. Okay, so the other thing to mention is that risk is higher if your partner is uncircumcised, because they can then hide and multiply under the foreskin. It provides a protective environment. And so male partners being a silent space or reservoir of the germ is something that we're becoming more, we're coming to understand better, and could be what is helping in some women to trigger the recurrence. So recently we've had studies that have tested this. They've tested treating the male partners of women with recurrent BV with a combination of tablets, antibiotics, and antibiotic cream. And they found some really amazing results, that when the male partner was treated, the recurrence of BV in their women, their female partners, was almost cut in half. So this is a very new protocol. So it's not something that's national yet. It's something that is, we're still understanding this, looking at whether it will be replicated in all over, in different settings, because just because a study says that this happened here doesn't necessarily mean it's going to happen somewhere else. So this is, a fairly new study, but it's promising. That is really promising information and can be the answer for so many, many women. Okay. I would think that if you suffer from recurrent BV, then it's, your doctor might just need to think about the concept of treating your partner as well. And it may be that your doctor needs to refer you to a specialist, a sexual health specialist, a genitourinary medicine specialist, or gynecologist, to sort of sit down with both of you and consider the value of, partner treatment. So what does this mean for you? I want you to don't feel ashamed and do not blame yourself. Okay, BV is a common condition, and there are different risk factors that I already mentioned that could lead to that disbalance, that dysbiosis in the good germs and bad germs within the vagina. Now being aware of it, you can see it's nothing to do with hygiene, but it's about being aware of it and then reducing whatever risks. So for example, if you smoke, stopping smoking can help. That might reduce your risk of developing this and happening recurrently. If you're somebody who has an IUD coil and you keep getting recurring BV, then the next step will be to take away the IUD and see, if your symptoms settle down. Stop douching, especially if you're someone who experiences recurrent bacterial vaginosis. And like I said, if it's something that you have been struggling with, all manner of treatments, you keep getting the infection and so on, it is worthwhile having a conversation with your doctor to sort of look at what are the next steps. How can we move forward with this situation? Guys, I've just realized that throughout this conversation, you have not seen my face. All you have been looking at is the picture of the BV germ. My apologies. I think you've got the information that you needed to have. And I think it's getting to that time of the day when, I'm getting tired. But I think I've had a really interesting conversation with you guys, as many of you that's joined us live, popped in to the stream every so often to have this conversation. Thank you so much for doing that. I think we're going to call it a day, because it has been a big day full of information. We have covered so much ground, okay? We've demystified pelvic floors. We've talked about postpartum recovery. We've looked at navigating menopause, and we've just talked about new ground on BV. So I'm hoping that you're feeling more informed, more confident about your health. And, this is just the beginning. Health empowerment comes from taking the next steps, using these insights. Take the next step, speak to your practitioner, speak to your doctor. If you need to book that appointment about your smear, if you're worried about cysts, have that conversation with your doctor. Start putting together a symptom journal, if that's something that you've not been doing in the past. And the conversation doesn't end here. We have lots more resources, lots more articles. Head over to askawayhealth.org. I've got loads and loads. In fact, you don't even have to leave here. Stay on this channel. There's lots of women's health information right here. Okay, and of course, if you want to book an appointment with me, if you're based in the United Kingdom, it's yourgpconsultation.com. Do me a huge favor. If you found this valuable, please subscribe to the channel, and of course, hit the notification bell so that you don't miss our next deep dive. And I would love for you to let me know which of the topics was most useful, most valuable for you today. That feedback will help me in designing the next deep dive. But yeah, I just want to appreciate you for taking the time to join me today. You are your own best health advocate, and by staying here, coming in to have this conversation with me, you've shown that you care about your health, care about having conversations to improve your health, and I look forward to seeing you again in the very next one. Thanks, guys, and